Thanks to advances in medical science, children being born today can look forward to an ever-increasing lifespan. Rh babies can be diagnosed and treated while still in the womb, so that their births cause little more difficulty than a normal child's. And while leukemia is usually still fatal, a few cases have actually been cured, while the rest have been given longer, more comfortable lives. Doctors can even intervene in the dying process in an older patient in a way that would have been miraculous only 10 or 20 years ago. In the first two programs of our series on science and religion, we heard from scientists speculating on the effects of their work on generations to come. But doctors of medicine like Barry de Weber have to make decisions which will every day determine the death or life or the quality of life of their patients. Advances in scientific knowledge are often double-edged. We can keep Rh babies from dying, but we can also keep alive babies suffering from Down syndrome, Mongolism. They used to die at birth from congenital defects or die young from disease. Now we can give them an almost normal lifespan, years during which they may be a burden on their parents or on society. This has led some doctors to ask, how hard should we try to keep these children alive? While we were at Children's Hospital, we visited the doctor's rounds one morning and heard one such baby discussed by the doctors, interns, and medical students.
Okay. Thank you, Barry. To tell you briefly about this child, is a young lad now who is 10 months of age and has been in this hospital many, many times. He has Mongolism, or Down syndrome. At about 3 months of age, his family doctor detected a heart murmur in him. And since that time, although the murmur hasn't changed very much, the child is presented with two problems: recurrent attacks of pneumonia and with generally failing to thrive.
Well, maybe Mark can tell us, you've seen the child, eh?
Yes, I've seen the child since 3 months of age. At that time, the child presented as a classical picture for congestive heart failure. That's to say the child had rapid respiration, rapid heart rate, big liver and spleen, and plus failed to gain weight well. So we put the child on digitalis, and then still, the child improved a little, still not doing too well. Seems in a stage of so-called chronic congestive heart failure. That's to say the heart's still quite weak.
Now, what would you say the natural course of this disease is, or what will happen to this baby if we do nothing?
If we do nothing, one of the most important things is the child could die in one of the pneumonia.
These are the films taken most recently in his last admission, but they're not unlike many of the previous films that have gone on in past admissions. And I think the significant things to show you on this chest x-ray is an increased size of the heart, increased pulmonary vascularity, and two principal patches of pneumonia, one in the left upper lobe, seen here on the PA film and here on the lateral film, and another patch up in the right upper lobe.
So you're going to try and get this chest in a little better shape, and you're going to catheterize the child to try and pinpoint the defect, and then you're going to consider surgery. Well, now, how do the parents feel about this?
Well, although the picture does not look entirely rosy right now, the parents are willing to go along with any measures that will improve their child. This little boy is a bit of a heartache and a lot of work at home, but he's an integral part of the family and really loved. And the family want him to get better and get home and get cracking on with the business of life.
We laymen always think of doctors as being in the business of prolonging life. And I'm wondering if there's any time where you ask yourself the question, is this really life that I'm preserving? Are there not times when you decide perhaps that this patient should go?
Well, I certainly see a lot of this in the leukemia patients. It's a classic situation where they're at the very end stages of their disease and maybe suffering somewhat, and where to treat them vigorously would be, to me, wrong, in that you are prolonging their suffering. It's difficult, though, because very often they're in pain, and in order to relieve their pain, you have to treat them specifically for their disease. And I know the residents and interns will often accuse me of prolonging life unnecessarily, and I have to try and convince them that I'm treating these children strictly to relieve their pain, that I've already decided in my own mind that the sooner they die, the better. And I can't actively do anything to make them die, but I can sort of indirectly do this by not treating them very vigorously.
Well, let's take a situation of a newborn child that has been, obviously has Down syndrome. Do you not think sometimes perhaps we should withdraw treatment in this situation?
I don't think that you ever should, particularly in the newly born, where the life expectancy is tremendous, even in Down syndrome, that you really don't know what the future holds and how productive the child might be. There are many children with Down syndromes that are relatively bright, and certainly they give a great deal of enjoyment to their families. And I think in the newly born period, it's far too early a time to decide what the fate of the child should be.
But surely there must be cases where the parents urge you to withdraw treatment in a case like that. Do you not listen to them at all?
Well, it's difficult because very often you do put the question to them, you know. After all, it's partly their responsibility, but very often they're really looking to you for guidance. So I think that very often they are depending on the doctor. And
It just occurs to me, though, that by this decision of yours to prolong that child's life, you're, in a sense, sentencing that family to live with this Mongol child. And, you know, it's out of your hospital. They're the ones that are going to have to live with the child, not you.
Yeah.
You're sentencing the family to live with the child that they had already intended to live with anyway. Now, whether the child is a Mongol or has some other deformity or is normal, it is their child, and it has been their choice to produce a child. And in many instances, they have been aware of risks in having children. We all know that a small percent of children will die, a small percent will be deformed, so you're just presenting them with the child that they have always wanted.
But this, you know, worries me a bit because I think it's all part of the tendency nowadays for people to want perfect babies. I think people get pretty upset at the idea of a baby that isn't quite right. Mm-hmm. And they may not want it at all, or they may want it, not want it operated on. So that there again, it depends on the parents' influence, you know, from society. And I think now society is influencing them not to accept these children or not to let them live.
Like the baby that the doctors were discussing earlier, Anthony is not perfect. He is 10 years old, but he too has Down syndrome, and his mind is that of a 4 or 5-year-old.
Fish? I'm sick of fish.
Oh, come on, Mom.
Oh, Anthony, all we ever do is play fish. Okay, how many cards should you have?
3.
What's it like at home with Anthony then?
Kind of wild. Well, he's really a very happy child. He's mischievous, and he eats too much peanut butter, which I worry about, but I think he adds to our family myself. When he's not there, it just isn't the same. I guess that's it. And he's been away now for 2 months, so 3, 4, 5. Okay.
Is there special treatment that you have to provide at home?
Just keep an eye on him and keep him out of mischief.
How were you told about Anthony's condition?
Well, we were told the day he was born. Yeah. 5? Maybe I knew something was wrong because the baby didn't cry right away. And, you know how they put the baby beside you, and I was talking to him. He just didn't respond, I guess, like my last child had. And he came in with his nurse and stood at the foot of the bed and just asked me if I knew anything about Mongolism. Now called Down syndrome, of course, but at that time. And proceeded to tell me. And then he called Tony, and then we cried for a week, and I guess that's about it. Who's going to win the prize? Eh? Who's going to win it? You or me? You? You are.
How did you feel during this time? What sort of questions were you concerned about?
How will we handle this child, or will we keep him? That was the biggest thing. Well, we won't keep him, you know. Then we were referred to CPRI, which is the Children's Psychiatric Research Center. They just told us, well, that they didn't think the child would live if we didn't keep him, so we kept him. It can go on for a long time, this
In other words, if you had put him in an institution, he might not be alive today.
Mm-hmm. I guess so. That's a pretty drastic thing to have on your shoulders, isn't it? The death of someone you've just given life to.
Mm-hmm.
Would you like to look at a book? I'm getting sick of playing cards.
Well, okay.
Want to look at a book?
Yeah.
Okay.
The problem comes when the parents decide that they do not want the life of their retarded child saved. Certainly the doctor has an obligation to them, but he also feels an obligation to save a human life. How can he be faithful to both obligations?
I attempt to tell the parents all, or as much as is sensibly known, without going out and conjecturing out on the limb. They have seen the x-rays. We discuss the child with them twice a week when they come down to visit. They're aware of everything that's going on. They're aware that there are risks in some of our investigative procedures. They're aware that the heart might not be able to be fixed, and they are fully aware that even if the heart were completely normal, they would undoubtedly be faced with a child who is mentally subnormal for the rest of his life.
Have you even hinted to them that in some cases treatment might be withdrawn?
No, no.
They wouldn't even consider this, you think?
I don't know if they would consider it. I wouldn't.
It has happened in our hospital at least once or twice where exactly the situation has arisen. The parents didn't want the child operated on, the surgeon wasn't keen on it, and it was not operated on and died. So
the decision should lie to the parents. I think after being told of the say the consequences of operations or of the child itself with this type of defect, I think they should be told completely about it and then leave it to the parents, and we should be the ones who should help them or support them of their decision.
But then, having said that, are you willing to go along with their decision if they say our decision is to withhold treatment?
Sure, I would.
You would go along with it? How about you, Dr. Eccleston?
No, I wouldn't. The child is the responsibility of the parents. I grant you, doctors and clergymen and priests and social workers and psychologists assist in making the decision. But it is the parents' child, and they must accept responsibility for it. But the decisions that they make must be sound decisions, and we, and perhaps the legal agencies, are there to make sure that they're kept sensible.
Say this child was operated upon, we did quite well. The emotional attachment is quite high. They really get very absorbed in the child. And I've seen one case where this thing did happen, and the child came up in congestive failure and died. There was a lot of resentment by the parents, and because they got so fond of the child that they forgot about the other children. So there are many factors to take into account.
well, I've seen one family when I was in general practice with 7 children, and a lot of them young, where a Mongol child was kept at home, and the mother spent so much time with the Mongol child that really the whole family suffered. Now, I'm not saying that's the reason to let the child die, but I think it can be a problem.
Well, you must remember, though, that there are many crises that face families and face all our families. When it's very easy to lay the blame on the Mongol, but this family probably would have crumbled from some other adverse reaction. I don't think this is a valid argument for prematurely neglecting treatment in children.
The other question comes up, supposing you elect not to do surgery, what's going to be the mode of dying? This child can linger on and on and on and get more dehydrated. And then day by day you're faced with the decision, do you start an intravenous? Do you do some other operation to keep this child alive? And the prolonged agony of having to make these decisions is still with you. You don't, by refusing surgery, you don't duck your responsibility. You're faced with this responsibility day by day.
Well, what in an older situation? Let's take middle age, for example. A person perhaps is suffering severe brain damage. Do you then keep that patient alive?
Well, of course, we don't deal with the older age spectrum, but to me, there's not much difference between taking an older person who may be semi-conscious or since I've seen in my family recently, who died naturally, but this man was really literally a vegetable for years. I mean, he couldn't recognize anybody. He was walking around. He wasn't lying in a bed, but he was totally, I think, out of touch with the world. I mean, there was no one that could really make sure he was making any contact. Well, to me, that would be much more logical to get rid of someone like that than, say, a baby. A Mongol child, as you know, are fairly happy children, and most families who have them don't have that much trouble with them.
Well, Dr. Eccleston, what about the old patient who is full of cancer, then develops pneumonia? What's the natural course of events there?
Well, I guess every case must be taken on its own merits, but probably the outlook is is very dismal from the point of view of the length of time left to live and also the productivity left to live. And in this case, I think your duty is to relieve pain and diminish the suffering, and by whatever mechanisms you should. So the use of drugs to remove the pain is your primary concern, and I don't think that you would necessarily actively, if at all, treat the pneumonia. For the expectation, even if a cure were suddenly obtained, say from the pneumonia, is very poor because the malignancy would carry on and do the person in, or if magically the pneumonia were cured and the malignancy, then the patient is probably still at an age with other infirmities that would not make him very productive.
But even surrounded by tearful, pleading relatives, you wouldn't hasten death in any way.
Well, I think there's a difference in hastening death. That is almost an act of commission.
Yes.
Where an act of omission is withdrawing or withholding the antibiotics. Perhaps it's a very subtle difference.
Because by withholding antibiotics, you're sort of letting nature take its course. And I think you could be criticized for overtreating someone like that. But to actually go in actively and give them an overdose of morphine, that is a positive act of killing, you see. And I think there's a big difference.
How do you arrive at your philosophy of a patient's right to life?
Well, I don't think our philosophies are probably that much different than yours or anyone else's. You acquire it through living, through your family experiences when you were a child and how you were brought up, on your religious background, on your experiences. And then you sort of determine in your own mind what the quality of life is and how diligently it should be preserved.
I simply think you have to take the view that all forms of life are fairly sacred or precious. And this includes the vegetable, the severely retarded child, even the person in the coma, and the unborn child, that they all are forms of human life and they all have something special about them. Well, now that is a general principle that I would follow. Now, in individual cases, you might get away from that principle, for instance, the terminal patient, and you would say, well, yes, he has a right to life, but obviously his life is, well, in some way it's not right to prolong it. You know, like there's one quote that I read somewhere. It said, thou shalt not kill, but thou shalt not strive officiously to keep alive.
How much of your religious belief forms a basis for your philosophy about life?
Well, of course, being in the Catholic Church, we have very strict guidelines put down, and this puts a challenge to you, whether you're a doctor or anything, and you have to look at these guidelines if you're going to be faithful to the Church and see whether you're going to buy them or not.
If you are faithful to your religion, then you also want to be faithful to your patient. Do you really have a right to impose your religious beliefs on your patient?
No, I've never done that.
Well, let's take an example, not necessarily you, but a doctor who is a devout Roman Catholic and knows the church line on abortion, obviously would not perform an abortion for the patient.
No.
Is he not shirking his responsibility to his patient?
No, I think he's, no, I don't think he is, because I think he feels, as many doctors do, that this is a small, this is a baby, it's a live human being, and that it really shouldn't be destroyed.
Yes, I think you must appreciate this. There are many of us non-Roman Catholic physicians who basically do not approve of abortions. But the difficulty you run into is if you adamantly disbelieve in them and won't perform them or suggest that they be done, I think you have an obligation as a physician or surgeon to offer a reasonable alternative.
Well, I'd like to move this back a bit because, as I said, if this lady was not sterilized and was pregnant again and had an amniotic tap and the chromosome study showed she was carrying a Mongol, the decision then would be, should that baby, before it's born, be allowed to live?
Do you mean this woman, if she were going to have her fifth child
Yeah.
and we'd shown it to be a Mongol?
Yeah.
Well, I guess this gets into the whole discussion of abortions. I think this is a very reasonable excuse to do an abortion, to be unquestionable in this case. I don't know what this mother's attitude would be, but I think once having been through this episode with this child and perhaps faced now with a fairly premature death, she might go along with a therapeutic abortion.
But then you're making a decision to destroy this life. Why can't you make that decision at 1 week after a natural delivery? The decision to destroy by not performing surgery.
I think all of us, on the basis of perhaps our religious beliefs and our heredity and our educational background, have to define when we think life begins, and probably this is without the scope of this conference this morning. And I think probably you have to morally settle this in your own mind.
Well, supposing there was a normal child that wasn't a Mongol.
You're cutting this very fine. Now you're making a distinction. Is it worthwhile to let a Mongol live and a child who has a normal number of chromosomes not to live, which is entirely foolish. Both children are equal, and they both should be treated.
But the idea, the thing we are arguing is the anomalies with it. The chances, because we know that the lifespan is shorter. Though they say it's up to 60, but with heart and other problems, they might die earlier. So this is taking that into account that we are arguing.
I think this come up to the point is that, if you allow IQ 90 as a normal, and then, the Mongol, they have IQ of 40 or 50, and then you let them die. So we draw a line now, and, we let everybody with IQ of 50 die. And then about 5 years from now, we say, let's put it up a little because, the population grows rapidly. Let's let all the patients with the IQ 55 die. And then gradually go up to 80 IQ, it's not going to survive.
You mentioned that your philosophy of life would like to be the same as mine or many other people, and yet I'm not faced with these life and death decisions, certainly on as regular a basis as you are. And I'm wondering, there must be times when you feel that you're playing God.
I don't think these are really decisions. There never really is any decision about it. If you have a clear mind and adopt the attitude that what you are going to do is preserve and prolong life. How actively you do it is another matter.
I'm rather glad to hear that, because I sort of pictured you agonizing over these decisions on a daily basis or something. Maybe it's not the...
Well, I think there's a bit of this goes on in the terminal patient or the leukemia child, more because of what the parents might feel. I mean, you get the situation where the child is very terminal and has only days or weeks to live. You're not sure, though, what the parents think. And I would often write on the chart, do not resuscitate this child. Or this is a palliative case only. But the parents, you see, may not feel this way. And they will come and say, how come you're not transfusing my child? Now, to me, giving a blood transfusion to a child who's obviously dying fairly quickly, peacefully, painlessly, the ideal way you'd like to see someone die, to give them a blood transfusion, it would be ridiculous. And yet, the parents are insisting on this, and on occasion I have done this. And this baffles the residents and the nurses. But I'm doing it more, almost to treat the parents in a way, because I don't feel it's fair to them to go through this agony of that their child isn't being treated.
You've mentioned that your experiences and your family life, your religion, all of this plays a part in your decision-making process. How about your medical training? How about the schools? Do they have courses, sessions in ethical decision-making?
They didn't when Barry and I graduated at least 10 years ago. I think more has been introduced into the schools more recently as curricula are upgraded and improved. But most of our ideas have stemmed just from practice and sort of what we've learned.
Well, I used to conduct sessions with students for this purpose, because I felt they were suddenly interns with a big responsibility and had never thought of any of these problems, like the dying patient, do they resuscitate them or don't they, and so on. Now I'm pleased to see in our new curriculum here there is a course called Man and Society, and I'm told that that's a fairly big block of time, and that in it there will be something on ethics and the law, and that many of these questions will be presented to them at an early stage in their medical course, so at least they've been used to thinking about them. Because I think it's very unfair to a young doctor to be suddenly faced with one of these acute, crises and not having had any sort of idea or background.
But you must remember, I think it is intended that the presentation to them is not to give them the answers. You do this in this situation, and this and that. It is just to get them to reevaluate themselves and further examine situations and see all sides of it. And it just helps them in making their decisions. Now, whether it is actually taught as a specific course in school or whether it's gleaned through years of experience, perhaps the outcome is the same.
When you daily have to deal with death, it can make you think a lot about the nature of life. Not many years ago, most of the questions in this program never came up. A doctor could never save enough patients. Now doctors can prolong life, whether in a newborn baby or a dying old man, under conditions which force them to ask, isn't this still a human life we are preserving? Or would it be natural to let the patient die? Dr. de Weber feels that too often our answers are based on pragmatism and practicality, rather than on an awareness of the uniqueness and sanctity of human life. The answers to these questions are difficult, but they tell us a lot about our attitudes towards human life, and a lot about ourselves. I'm Roy Bonesteel for Man Alive. Good night.
We can do something. I think we have to be present. We have to show them that we are ready to give something of ourselves.